I'm preparing to go. Trying to. All right, Jenny, I'm ready whenever you are.
Okay, you're ready when you are. What are you thinking with Mike? Should we give him another minute or should we just get started? I didn't hear anything from him, so.
Didn't either.
Well, we can get started, and if he joins in shortly after, we'll count him for being at the board. So I'm going to call the meeting to order at 3:02. As far as roll call goes, Brenna, I think you can just take attendance via who's attending via Zoom, correct?
Yeah.
Okay. We're going to get through a couple of the agenda items, and then when we introduce Keith, I'd like for all of us to go around and do an introduction as well, just so Keith knows who everyone is on the board. But first and foremost, if we can take a look at the consent agenda. Does anybody have any changes to the agenda, which includes our meeting minutes from the last meeting? If no one has any changes, I would ask for a motion to approve.
It's Chris, I'll make the motion.
Thanks,
Second.
Chris. Okay. So we have a motion and a second. All those in favor signify by saying aye.
Aye.
Those opposed, same side. Motion carried. All right, first on the agenda under operational update is our new groups. Brenna, did you want to share those numbers or is that Randy?
I think there's 2 official new groups. There was also an REA in the state that combined with another REA, so they kind of make a new group. But Granora Public Schools and Kensal were 2.
And then for January, we have Jamestown Parks and Rec and Foster Public Health.
So we have 2 in the October pool and 2 in the January pool so far that are going to be new.
Yeah, yes, and Foster hasn't completely committed, but I think they're in that final stage. But Jamestown Parks and Recreation with 26 employees has committed. So I think John's just waiting on the final from Foster.
And do you know offhand how many groups that is for us in total now? Sorry, I didn't mean to put you on the spot, but just curious if you have that number.
It's 125.
26.
26,
I
yeah.
thought we were already 122.
Yeah, that'd be cool. Yeah, right.
Yeah.
126.
Okay. Not bad for our 3rd year starting a trust.
Yeah.
Randy, I thought Wilson Park District was joining too.
We looked at them, and their underwriting wasn't very good. So I think that's John's got the more detail.
Yeah, part of the challenge is that many of the groups, of course, since we're in the middle of the biennium for NDPHIT, there's not really a pain point until they get their renewal this coming July. And Williston Parks definitely fits into that mix where if we did invite them into the trust this year, again, based on their claims activity, we couldn't give them a discount to their existing rates. So it wouldn't really make sense for them to join this year, but we had a really great conversation and they intend to look at it again next year.
Okay, thanks for that update, John.
Yeah.
Okay. Moving on to the NDPHIT appointment update, as many of you or all of you know, the Insurance Reserve Fund has hired Keith Peach as their new executive director. He has been part of claims, but I will leave his introduction, I should say, up to him, but we'd like to welcome you on behalf of the NDPHIT board, Keith, and if you want to just say a few words to introduce yourself. And then I'd also like to have each board introduce themselves as well, so he knows who is all on our board.
Awesome. Well, thanks, Jenny. Again, my name is Keith Peach. I am the new CEO of NDPHIT. I've been at NDPHIT since 2012 and started as an outside claims adjuster, eventually moved to the assistant director of claims and then the director of claims. I have military experience from the North Dakota Army National Guard. My education background, I graduated from NDSU and then have a master's degree from Florida State University in risk management and insurance. I'm married, have 2 kids. My wife is very busy running them around right now with fall activities, as I'm sure many of you can relate. And that is my introduction, Jenny. So thank you.
All right, thanks, Keith. And again, welcome aboard. I'm Jenny Dietzman. I'm with the North Dakota Association of Counties and serve as the Director of Operations there. So, Paul, you want to introduce yourself?
Yep, Keith and I met up at Walker City last week at our state conference, so you're making the rounds. So we've had the opportunity to meet each other, but again, Cole Higland, Mandan Park District.
Desi.
Hi, I'm Desi Callahoo. I'm the Director of HR for Dunn County.
Chris.
Chris Larson, I'm the superintendent in Milner.
Steve.
Steve Holland, Superintendent of Schools for McKenzie County #1 in Watford City.
Sonia.
Sonia Larson, Kidder County School District Business Manager, and I serve on the Board of Directors for North Dakota Insurance Reserve, so I know Keith.
Yeah. It's kind of nice to have cross connections with a number of folks as well. Randy, have you officially introduced yourself yet to Keith?
No, I've never met Keith. So
Okay.
I'm Randy Johnson. I'm Senior Vice President for Brown & Brown and been with kind of the formation process of the trust since the beginning and look forward to meeting you in person someday and being able to work with you.
And Brenna and Angie, if you want to introduce yourselves as well.
I'm Brenna Yonke. I am the Director of Financial Services at Southeast Education Cooperative. We are the trust administrator, I guess is what we're called. So we've been around since the beginning of the thoughts of schools coming on board an insurance trust. And then my boss, who's now retired, that's how long this has been in the works, met up with Brennan, who has also had the same kind of idea for the public subdivisions, and so together they formed this this trust. So we work with a lot of schools on professional development, after school programs, a lot of grant-based work on our day job, but then we help with the trust also.
And I'm Angie Ahmed. I am employed with SEEK, but my function is the NDPHIT Benefit and Compliance Managers.
She's being pretty humble. Both of those ladies do a lot of work for us and we really appreciate it. All right, John, you're up.
Hi, Keith. My name is John Heath. So I also am with Brown & Brown. We work as the consultant for the trust. And I do a lot of the front end interaction with groups that are interested in coming in and also consulting on strategy. So excited to have you on board.
And Stephanie.
Hi, I'm Stephanie Mace. I work with Brown & Brown, and I basically act as the account manager for NDPHIT and manage the operations, renewal, implementation processes.
Thanks, everybody,
Awesome.
for
Yeah,
introducing
thank you.
yourselves. Did I miss anybody? I don't think so. Nora, I would have you introduce yourself, but considering Keith is your boss, I think he might know you.
We might work together on a pretty regular basis.
Yeah, I was going to say, I kind of think you might have had coffee a time or two. So, but with that, I would like to say, Nora, thank you for being willing to step up and to serve as a voting member on our board while there was a transition time of filling in that executive director position for the Insurance Reserve Fund. We really appreciate you being part of the team. And even though we're going to be ratifying the appointment of Keith. You are still a really important part of our team on the fiscal side, and we appreciate your efforts as well for the NDPHIT board. So with that, we do need to ratify bringing Keith on as a voting member of the board, and I would request a motion to approve him as the appointment for the Insurance Reserve Fund.
I make a motion, Sonia.
Is there a second?
I'll second Steve.
I forgot with Zoom, it's harder to do a motion of yays and nays. So I'm just going to say if there's any opposition to the motion, signify by saying aye. Okay, motion's carried. Next agenda item is the Taylor Walker Reserve analysis. So this was done in a prior year. They look at our actuarial information, and again, Randy even stating that we've gotten four new groups on our policy. We've grown quite a bit since the last analysis was done, and so they are recommending that we do another analysis. This helps us determine what our reserves should be set at. And Randy, do you have anything else to add as far as this process goes?
Start again, sorry.
Yeah, 2 years ago, it was done by Taylor Walker, which is a third-party actuarial firm. And they looked at our rating process and the plan designs that we currently offer. They also look at the tier structure that we have in place, which we've talked about a lot at the board level, as well as the adequacy of the stop loss levels that we currently have. So just so you're familiar, Keith, we have a $300,000 stop loss level that applies at the trust we have two pools. So they will look at that again, just to make sure the stop loss is set at the appropriate level based on our claims history, our high case activity, and our pricing. Then they also looked at our reserving approach as to how we're setting our tiers. We adopted some of those recommendations that they made historically and have expanded that to, in conjunction with our renewals. And then the last thing is a fund balance reserve analysis, just to make sure that, what is the amount that based on our current premium, our current reserve, our IBNR factors, that we have enough that we are allocating as a function of the premium to continue to increase the planned reserves, and also what is, as we grow in premium, what should we plan for in subsequent years? So realistically, this should probably be done every 2 to 3 years as we grow in premium and as we add additional member groups, because there are variables, of course, that take place because of that growth and the fluctuation of claims and new additional members. So I contacted Scott. He is the chief actuary and the managing member of Taylor Walker. And he indicated that they would do a similar study to what they did historically. And the turnaround time would be about 3 weeks to a month, so that we could have that available before the next board meeting. The cost would be similar to, I think, I can't remember what they paid, but they charged last time, Brenda. I think it was 5,000 or 7,000, something like that. But it's going to be similar in cost. He said this year, in doing this, it would be between actually 7,000 and 10,000 for the one-time study to include all those components. So in conjunction with that, we just think it's a good practice to have an outside review by a third party outside actuaries. So that's the scope of it in terms of what it will include and the time frame and the cost.
Well, and again, Randy, when I look at where our premium amount was 2 years ago, it is significantly different from where it was in that short of a period of time. So even from that aspect, being able to get that full review and making sure that we're fiduciarily responsible and where our reserve should be and looking at all of those factors, I think are important. Does any board members have any questions in regards to doing the analysis? Okay, we will need board action on this. Could I have a motion to approve to move forward with conducting the reserve analysis with Taylor Walker?
It's gonna be more than reserve though, it'll be all of it.
Yeah.
Anybody want to entertain a motion?
I will
Chris,
make a motion. All right, I'll second.
either way.
So Chris made the motion and Steve Holland seconded. Thank you. Any further discussion? Okay, those opposed to the motion signify by saying aye. All right, motion carried. Next item on the agenda is the Health Committee. At our last board meeting, we had some discussion in regards to having a smaller committee form with board members as well as some of our outside representatives or entities that represent NDPHIT to discuss different things such as, what type of standards that we want to have within our NDPHIT trust. Do we want to look at, standardizing plan designs, those types of things. And so we thought it would be a little easier to have a subcommittee put together to be able to discuss those options, and then those recommendations from the committee would be brought to the board for consideration. Brenna did a great job in reaching out to some of our non-board members for the committee. So currently who we have is myself, Mike on the board, as well as Desi. And then Shannon Davis is with Stutzman County. And Roberta Engel is, which school is she with again, Angie?
Park River, Hinkle.
Park River School District.
Yep.
We did have another individual that was going to serve, and I think it was Sonia, but there was just too much going on, I understand, as far as a commitment. And so we have one vacancy that we'd like to fill. I would like to discuss with the board if you think it would be more appropriate to have another board member serve, or if we would want to bring someone outside of the board. Currently, we have 3 board members serving and 2 non-board members.
I think it's good to have somebody not on the board, so that way then we have a feeder program of people who are learning the processes, and as we have change, we can bring somebody into the board.
Mm-hmm. Brenna, I know that there was someone from Valley City. Go ahead.
Carl.
Yeah, Carl. He is the city administrator. He's also an attorney that we've interacted, John and I have interacted with him multiple times. He's always been very supportive and very well engaged and always asks lots of really good questions. And I think that, I think he would be one that, as a non-board member that probably, if he's willing to serve, he would do a good job and be a really good contributor.
I can reach out, Jenny.
Okay, that would be great. Does anyone else have any recommendations for a non-board member that would be someone who would be willing to serve or maybe would have an interest in serving on the health committee?
The questions I'm getting when I'm approaching people is how often this would meet to just prepare them for the commitment, and they don't want to commit to something they can't work into their schedules either. So are you thinking once a month, or are you thinking more often than that?
I would not think we would be meeting more than once a month, and honestly, I really think it would ebb and flow depending on what topics we would need to decide. I know, like right now, a couple of the things we're looking at is standardizing some plan designs. So maybe once a month, maybe for the first 6 months, and we can always reevaluate depending on what the needs are.
Mhm.
I know, Mike, you just popped on, and Desi, would you see us meeting more often than that?
And is it something?
Yeah, I mean, I'll give you an example. Kid I coached, there's cats, tools. I literally took her out.
I'm not sure who that was. I don't know.
I think it was Kevin. I'm not sure if he knew his
I
mic
don't
was
think
on.
he-
But
Oh,
that's
okay.
different, like,
Do you anticipate it being during the day? Jenny? During the workday or at night?
So here would be my question. If it's with school administrators, is it better to do like at 4 o'clock? Or would
back
they,
and focus on.
Yes.
I would say yes during the workday, but if later in the day works for our school representatives, I think we can definitely be flexible on that.
Okay,
I'd even go a
Mike,
little,
what are your thoughts?
I'd even go a little earlier than that if it works for people. Personally, so 2 o'clock. 3
Okay.
o'clock.
perfect. Just wanted to
And-
confirm.
Yeah, and Brenna, maybe once we get our final member on the health committee, we can do a doodle poll or something like that, that we can determine what would be the better times for people to meet.
Yep, for sure.
So we're hoping that with this committee, we'll be able to, I don't want to say hash out things in the weeds, but really be able to dig into certain areas to be able to kind of flesh out different scenarios, what we think would be pros and cons to different subject matter that the board would like us to look into. And then to be able to bring those recommendations to the board from that standpoint. And again, we would be looking for feedback from the board if there's areas that you would like the committee to look into. Also, if there's going to be things the committee sees that we feel may need to be looked at or addressed with the board, we'll do that as well. So again, it's a new committee, something that we're trying. If anybody has any other suggestions from that standpoint, that would be great. But I would say, Brenna, if we meet once a month to start out with, maybe an hour meeting, and then try to get those on the calendar so we're not scrambling every month to try to find something, we'll figure something out. Okay, so you'll meet with Carl or reach out to Carl.
I will.
Okay, maybe if he is, hopefully he's interested. If he is not, if you can let us as a board know, and then if anybody else may have some recommendations, if Carl is not interested in serving, I think that would be helpful as well.
Okay,
Yeah, and if Carl can, when I say I'm busy, I got chosen as one of the 6 business managers in the state to be like a mentor to other business managers, and it's kind of kicking off here, and so I'll see how entailed and how much time consuming that is. And so in the event you can't find anyone, let me know and I'll see what all these other things are going to entail, and we can go from there.
Sonia, we'll do our best to find someone. Because that sounds like a big commitment.
I feel bad because I do feel like it's business manager plays a huge role in working with all the aspects of NDPHIT, even more so really than the superintendents on the back end of things. The big decisions on how we want to run things as NDPHIT, ultimately, we want the superintendent's input and stuff. But so yeah, I feel bad. So if you absolutely can't find anybody, let me know.
Thank you, Sonia. Appreciate that. All right, Steve Holen, you are up. Tell us about your experience at the training session that you went to. Was it in?
It was Las Vegas.
Vegas. Okay. Yep.
Yep. Yeah, and I guess first off, thank you for the opportunity to allow me to go to that. I know that it was mentioned, I was at the initial board and some of those grassroots efforts with NDPHIT as a school district. So always intended to go, probably should have gone earlier. It always conflicted with schedules or otherwise, but really had wanted to make an effort to do that. I think we're maybe the largest employer in the group. And I've been in a lot of boards over the years, just of a variety of nature. So you just get used to being on different types of boards, oil and gas, all those type of boards. This is a little bit different. So I just feel like it was either unique as a trustee versus a board member. So I was looking forward to the training, and International Foundation of Employee Benefit Plans puts it on. Very professional. So again, I've been to quite a few trainings over the years, and they do a nice job. It is very well detailed, very laid out, very structured. It is 3 days, 5 4-hour sessions, and they go 4 hours. So they're very thorough. So I felt like, first off, it was beneficial in that way. Felt like I was getting a good experience in that regard. The first thing they do, they hand out a binder, and it's very thorough with that, but they do want you to build your trustee handbook, and they want you to have a common place to put your trust agreement, your investment policy, audit procedures, and so forth. There's a list of about 10 things to put together in your handbook. And to be honest, I mean, I think I could try to pull together some of those things, but I don't have them in a unified location where, you hand out to a new trustee and say, here's your handbook and reference as needed. So I thought that was interesting, that they did promote that pretty heavily. But it did get me thinking about a lot of those different things. Could I find them? Do I have a reference point of what those might even entail, and so forth? So it was good. And actually, I missed the June meeting, but I could kind of look back at that and said, okay, that's a unique perspective looking at that meeting and what I know where this is and how does it apply to what they're looking at here. So again, it's usually you look through the lens of school district to political sub. Again, at the training, it's a variety of people there. So it is unique to get the context of being part of a trust. I mean, you have labor unions, you have different capacities. It's not all obviously public, private organizations, so forth. So that's interesting, again, just get you out of the lens of what we usually look through. But the 5 areas were the trustee responsibility and legal environment, which was good. Very Taft-Hartley, you get the whole context of trust and so forth, which again, I thought was helpful. It does hit you a little bit. You talk about the legal responsibilities, again, of being a trustee and fiduciary responsibilities and all those obligations. And it's good to remind, it's just not one of those boards you sign up for and kind of sit and there you go. I mean, we are taking on a pretty good responsibility with the number of entities that we're dealing with and the volume that we're dealing with. So good context. The second one was investing, health and welfare, and pension plans. So the investment piece, which I find interesting, some may not, but that was, again, a good session to attend. The third one was an overview of retirement plans, which is outside the scope of NDPHIT. However, as a political sub who is living through NDPHIRS and TFFR discussions, I found it very beneficial. So that was a nice bonus, I guess if you can call it that, to get the context of those discussions at a national level versus our lens. So didn't feel out of place at all there. That was, again, fit the world a little bit outside of NDPHIT. But then the fourth one was this overview of the plans, which was really good, to hear discussions about stop loss and those type of things. And I wasn't very well equipped coming onto this board as a trustee in some of those terminologies in context, still learning on some of that. So that, to me, I thought was the last two, if I was a new member, really probably had the most relevancy, because the last one was governance. So there was really kind of covered the whole idea of, and again, been part of a lot of school board trainings, and you talk about governance a lot. There's just slight variations when you're talking about the governance in a trust versus a public entity and some of those other things. Some of them are common, some of them are not. So, but anyway, I really did feel like it was quality training. I've experienced many that are not. But again, it was very organized and very professionally done, which I did appreciate. And the context of the conversations of, they talk about collective bargaining agreements and so forth. And again, we're a little bit different because we're bringing in our own collective bargaining agreements. We don't have a unified one that a lot of the trustee groups have. But it was interesting to hear about that health committee, because a lot of the questions I did have is, are we going to evolve to having kind of a common plan, unified plan? Are those things in the future of once we evolve as a trust, versus all of us bringing our own plans in and then kind of evolving those over time. So very, very late to that. So I think, well, that health committee could be really interesting, because I think there's the next phase as we evolve as a trust. It seems like those be some of those topics that we would start to address that were brought up a little bit at the training that other trusts are dealing with that are you know, a little bit different in nature, but again, still common at the same time. So, yeah, I just, again, I don't know if, any more than that, but yeah, you do get this binder. It's fairly extensive. I found it really helpful because I've ironically referenced it a couple times already, just for variety of things that you see if they come up in the agenda item or otherwise, and it just brings you a nice context of what we are doing. I thought it was helpful. Again, been on a lot of boards, but needed to hone in on what this is as far as, you know, again, that title of a trustee versus a board member, and what are the responsibilities that we're supposed to fulfill. We do put a lot of faith into Brown and Brown and the administrator, which is good, but they talk a lot about, you know, what a board member should know and how to that role of, you know, again, governance and checks and balances and those type of processes. So, but anyway, again, I really appreciated the opportunity to attend. Found it beneficial for me, and you know, again, and took away something I think I could reference in the future as we go forward and so forth. So, I don't know if there's any questions or otherwise on that where it went, but I think Brandon attended before, but it was a positive experience for me. It is a time obligation, and they do make it worth your while. They don't cut out of the sessions early. They don't do anything. So, which is good because you pay there and you get what you pay for. So anyway, any questions or otherwise, again, thank you for the opportunity to attend. I really appreciated the ability to do so.
Well, thanks for sharing, Steve. And I think that you echoed prior board members who've attended that conference. And so for some of the new board members that are on, NDPHIT does pay for board members if they are interested in attending this trustee conference. And I do believe it's twice a year, Brandon, is that right? I think it's held like in February and.
Yeah, I can look up the latest one and email it out again. If anybody.
Okay.
Just so you guys have it, the latest dates coming up.
And I think that, you know, if you have the time available, particularly as a board member, and Steve, I think you hit on one of the things that I've struggled with as a board member as well. You serve on a number of different boards and you go in kind of feeling like your background prepares you for being a board member. And then you get into this insurance trust and there's a lot of information that there's a big learning curve. And so if there's tools and training opportunities out there for us as board members to take advantage of, I think that it would be great if each of you can find a time to be able to attend that training. So thanks, Steve, for sharing your experiences there and actually knowing that, you know, you're bringing things back and you're using it already on a regular basis. So that's great to hear.
Thank you.
Hey, Steve, was there a virtual option and did you win any money?
No and no. So I'm not aware of a virtual option. I don't think so. It didn't look like that from when they were presenting or otherwise. So, but I do know they have a series of these and it's a whole series of trainings. I mean, this is kind of the first level of them offered. But it was helpful to be in person, to be honest, because I did enjoy being able to conversate with others that are in different dynamics of their trust. I think there was, you know, California, New Jersey labor union members who are there as new trustees. Again, outside of where I usually delve, which is in the school political sub realm. And it was interesting just to hear the other part of it. So, but it was pretty full. I think there was probably about 80 to 90 that attended. I wasn't sure how many would be there, but I was surprised by the volume that were there for the training. So, but no money, no money won. Lot of warnings on as a trustee, you know, about regulations and in other environments, there probably might be more of accepting gifts as trustees and different, you know, honest, you know, things I didn't think about coming onto a board. I'm a little bit naive in that sense, you know, but so you get a bigger context of what it is to be a trustee in some of those environments. It's a fairly, you know, regulated and a lot of responsibility tied to it. So there was a lot of that kind of heavy talk that took place, but it was good.
All right. Any other questions for Steve? Again, Steve, thanks for sharing that with us. I think it kind of gives us a little bit of an encouragement to consider maybe registering and attending for that as well. Because again, anything that we have to take advantage of to help us grow and understand in this arena, I think is really helpful. Okay, moving on to the operational strategy part of our agenda. Randy is going to give us a Digby Health data and reporting update.
Yes, let me share my screen. See that.
And Randy, just thinking too, because Keith probably is not aware of what Digby is all about, maybe just do a 2-minute podium speak on who they are and why we partner with them.
Who are we talking about? Oh, Digby? Oh, yeah.
Yes.
So Digby is an organization that manages chronic diseased individuals, diabetic patients, but they got their focus and their start by doing managing GLP-1 patients. Interestingly enough, I think it was almost 6 years ago that they started this, before GLP-1s became a thing. Now they're a big thing. Keep, since you're newer at this, GLP-1 drugs have been a major growth issue in terms of our cost, that being drugs for Ozempic, Mounjaro, Zepbound, Wegovy. Those are the GLP-1s. And through our research and analysis, and we get lots of data, from our national organization on this, as well as our own groups, and that the growth overall in GLP-1s the last, I would say, 2.5 years has just been way more than anybody ever expected. So not only is it high utilization, it's a high cost, but the other thing that's been difficult is to measure return on investment for those employers who elect to cover it or not cover it. We actually inherited a situation with Blue Cross that we they do something very unique in terms of the way that they adjudicate claims for GLP-1s. And so we have to revamp the program essentially because of that. But we brought in a partner, that being a vendor partner, that being Digby, because they help manage patients in this environment. And their goal is to help educate and coach and handhold, or whatever you want to describe it. And then literally it's a one-on-one environment to help them understand, first of all, the genesis, if you would, as to their health condition, whether it's diabetic patient or a non-diabetic that deals with metabolic disease and other chronic diseases, and then help facilitate a process to help them understand that food actually could be a medicine in the positive way. So that's it in a nutshell what Digby does. And today I'm giving an update that started July 1st, this program with Digby. We also offered an option for individuals to look at a compound GLP-1 medication. And so I've got some update information on that as well. So this is to give you some sense where we're at. You've got Ozempic, and this tells you what I looked at is June compared to subsequent months. So we made the plan effective July 1st. So this reflects claims, as you can see, for what the plan paid, cost per script, what the member paid, and then what the member cost now per script is. And the way that, depending on the plans that were, if you recall, depending which plan you have as a plan, the way Blue Cross does it, if it's diabetic patients, that being Ozempic, Rybelsus, Trulicity, those were all available at typically no cost or $5 cost, or a very small cost sharing, even for those who are on high deductible health plans. So that's why you look at that cost in June, and again, just some context. If you remember, I showed data that went back about a little over 2 years ago, and our total plan cost at that time, the entire plan for the year, is about $360,000. We were trending to be, if you look at that number down at the bottom where it says June total plan paid, $305,000 which if you annualize that, we were trending to go to $3.6 million. So if you can just imagine that from 360,000 trend for a year now to 3.6 million, that is really the context we are dealing with. And it was just continuing to grow every single month. So you can see the overall at the bottom is summary of how it changed. So June 305, July was 158, August 169. So the average change per month, for August, as an example, compared to June was about 135,000. It was a little bit more, for the July change. But overall, if you trend even that change that occurred, it would annualize out to be about $1.6 million in savings to the trust. The one thing we observed, which has been interesting, is the categories dealing for diabetic GLP-1s, and that's Ozempic, Rybelsus, Trulicity, where you can see that there's not, and Mounjaro was in there too, at the very top, sorry. But the issue there is that we didn't see much movement change in either the number of individuals on the plan or the cost. Well, the cost share did change for the member, it did go up. But what I think this is this data is showing us is that those individuals in 6 months of the year have already met their out-of-pocket max. So they have no motivation at all to change. Even though that they have a new cost sharing going forward, they've already met the out-of-pocket max. So there's no more for them to pay. So they're just going to continue to write it out. So they won't necessarily be motivated to look for other options. Anyway, I think this is important data to kind of look at. So again, total plan paid change, 44% reduction, paid prescription, we went down 27%. The cost per member did go up about 44%. And then the number of individuals within that same profile from June to July to August, it decreased by 24%. So this is only 2 months, so it's really immature data, but I think it's relevant and important to look at.
Randy, just a question for clarification on those numbers and enrollments. Maybe you're going to get to it. So if you are, I apologize. But did we not discuss when Digby was going to start this process or this program that if you were non-diabetic, you had to have, before your prescription refill, if you will, would take place? Did they not have to go through Digby before they were able to renew their prescriptions?
Yeah, it's a good question. So anybody that, and we saw, I think there's some phenomena there. In other words, individuals that knew there was going to be a change, they may have renewed their prescription before July 1st. So that could have, pushed up a little bit of number in the June data. And then they're hanging on to whatever they got prescribed for the next few more months. So we actually will probably see even more change, in September and then August, October even, for those individuals where their script is run out. So they're going to have to renew it, and then they have to decide, do I want to pay 50% of the cost if I'm a non-diabetic? And then going forward, if you're new, so remember we grandfather anybody who's already on it. And if you're new to want to get the GLP-1s, you have to pre-authorize through Digby. And if you're diabetic, you actually don't have to pre-authorize at all through Digby. That goes through Blue Cross Blue Shield. So the other thing, just you brought up something that made me think about one other thing that we kind of observed, in that we are still finding individuals. In fact, we're seeing it, still come up where individuals were prescribed as a non-diabetic to get access to Ozempic or Mounjaro, which is only available for diabetics, but they didn't want to pay any money. So they had the provider give them, it's called off-label prescribing. So the provider is giving them off-label prescribing at zero cost. So we've got we have complaints of individuals who said, hey, I didn't pay anything before, but when Medallis has been doing the onboarding, that's one of their questions. It's a knockout question basically, and that is if you're non-diabetic, you have to pay a cost share to this. And they basically sign an attestment form that they're a non-diabetic. Those individuals have come forward and said, well, my provider allowed me to get this as a non-diabetic at no cost.
Wow, that's news.
Yeah, we shared that. We shared that with Blue Cross, that even though they think they've turned off the gate for it, it still exists. So the one thing that will be interesting to see is when all those out-of-pocket individuals max have been done and that are getting the diabetic class, when January, when they start having to pay a cost share, what they're going to do. So we'll see what happens there. The Digby assessment engagement, they show that they have 179. I just got this data updated from this morning through Alec and their team. But they have 55 members that applied for GLP-1s. They had 38 approvals and they had 17 denials. In other words, they just didn't meet the criteria to be qualified to be considered for a GLP-1. So their diversion, they call it a diversion, savings was just the first 2 months has been about $317,000. And then they gave the breakdown for the clinical conditions of these individuals who were actually in the program. So you can see digestive, chronic pain, skin conditions, sleep issues, mental health, cholesterol, and diabetes or prediabetes. And then they had, there was about 84% of those that get kits sent out to them. So that's part of the onboarding. So the majority of the people are actually doing the kit and returning it. And just in the last 14 days, they've had 91% engagement to those individuals that just in the last 2 weeks. The Medallis engagement, they have 52 patients who prescribed into the compound option. So the annualized savings just in that shift there is about $431,000 to the trust. And that's only with those 52. They get, obviously, if they increase that will grow. So if you combine the overall, the diversion dollars saved by Digby plus the compound option, it's about $749,000 of savings to the trust, which is 1.5% of the entire plan cost and about 5.6% of the entire pharmacy cost.
And those 52 patients that are enrolled in the Medallis compound, those are diabetic as well as non, Randy, or is that just the non-diabetic?
Yeah, that was, I researched that question. There's only 3 diabetics.
Wow.
The rest of them are all non-diabetic. Yeah. So that validates why we didn't get a change, what we showed you earlier for August and July and August data from Ozempic or Mounjaro. And this is also something we're going to talk to our team and Angie and Brenna about, but we need to create a better, probably a proactive communication to everybody just about what a compound pharmacy is. Because they're getting they've been doing this for almost 2 years now in the compound environment, and they're getting significant results. What they don't understand is how it's compounded and how the facility is actually overseen by the FDA, but they don't oversee the distribution of a product like through the manufacturer of Ozempic and Wegovy. And people and providers even don't understand the difference. So you have the FDA that oversees each of those compound facilities, and they have to meet licensure. They have to meet expert quality standards because they're a pharmacy. So when they produce that ingredient The only difference is they produce it to an individual distribution and not in the masses. But they have to actually meet the same standard to treat the patient. And actually, there's more flexibility because there's in the, if you remember, if you get the pen injection that comes from the manufacturer, it's pre-filled. You only get, there's 5 options basically that you have in pre-filled pen injections for Ozempic. But if you have a reaction to it, you're in one of the 5. But if you are through the compound, they can actually reduce the dosage immediately for what the patient takes. So it's more of a customization to the patient in a compound environment versus the standard injections that are available through the manufacturer. Those are just things that the members don't really understand.
Well, and I think you bring up a good point, Randy, and my wheels are churning from the standpoint of, you know, we have a number of people who obviously maybe did before July 1 up their prescription so they could, you know, have another 3 or 4 months with this without having to deal with the Digby program or any of those things. I know that this year NDPHIT is doing an active enrollment for all participants. I'm just wondering, and Angie, maybe you can answer this as well, but do you know when they're doing the active enrollment, are they going to be sharing information for those who may be, and I don't know if they can, but I'm just thinking, is that also another opportunity to be sharing with members the Digby program, talking about the compound for pharmaceuticals? Because if you're not, you know, if you're getting everything paid for, out of pockets taken care of, they may not necessarily want to know the information, if you will. But as those new out-of-pocket limits start over in January, is there an opportunity for us to provide some of that information about Digby as well as the pharmaceutical compound during that active enrollment?
So we added Digby and Medalis to the benefit guides that everybody has access to. That was added to those. If you're talking the active enrollment, it's not necessarily addressed within, like when they're actually completing the enrollment. Our benefit counselors, so this year is our first year of having benefit counselors available for people to schedule an appointment and work with the benefit counselor, and they kind of go through your plans and your options and all of those things, and they have the information on both of those. It's not probably something that they're really focusing on. I know in the October there wasn't a big focus on that. Because it will pertain to some but not to all, and they have so much time, so you don't, you know, you got to be careful what's highlighted and what's not. But I think there's definitely needs to be communication, more communication. We've communicated it a lot, right? But it also gets overwhelming because we're communicating a lot of things all the time. And so it gets to be overwhelming because we're going through the group contacts. There has also been direct communication with the employees directly to their home address, both from Digby, from Blue Cross, from NDPHIT. There's been several different campaigns, but it is something that we need to do another round of and probably focus on some of those things a little bit more. Now that we've introduced what the programs are, like the names, you know, even just the name recognition. I'm still getting calls every day where people are like, I didn't hear anything about this. I don't know anything about it. Which could be, could not be, you know, you get mail and you throw it away, whatever. So yeah, it's now doing that because we know you need to hear things so many times before you actually grasp it, or that until it hits you, until you're the one that's impacted, it doesn't mean anything, right? So we've talked about
was the original marketing pieces though, I thought those were targeted specific to those that were diabetic and also on weight loss, GLP-1 drugs.
We did both. We did both. We did a communication to people that were currently on it. And then we did a communication that was if you were intending to be on it. So basically we did it to everybody else then. So that everybody was hit at some point. But again, it doesn't mean that we don't need to revisit it.
But you're probably right. Maybe open enrollment isn't the right place to be having that discussion, because I think it could probably eat up the majority of the time with those benefit consultants, but maybe just being mindful of you know, with the new plan year starting, and I know the October plans, they're probably already done with open enrollment, but yeah, just something to keep in the back of our minds, because it is a new program and it's something that's, you know, that's very new and I think can provide a lot of benefit to those that are in those categories. So. Okay, Randy, I'm done. You can
Oh,
proceed.
no problem. Yeah.
Good,
no,
great, great,
good
great
discussion.
comments though, Jenny.
Yeah.
Yep.
The next one is, so that's the summary on that. Then next on the operational side for an update. Oh, before I get to that, just to give you kind of a context of, this is just a snapshot for year to date where we're operating as a trust. And I won't go through each one of these, but I think it would be helpful, you know, when you get this deck, you can review it and just again, as a side note, if you look at the bottom right where the top prescription drugs were, Humira, #1, which is not that's usually our top drug of all of our clients, just so everybody knows. Humira is, I would say, pretty consistently the #1. But then you see Ozempic, that's year to date for each of. Now, even this is in with the change that we just made. Just so you know, on Ozempic and Wegovy, and then Mounjaro is down there too. So 3 of the top 5 drugs are the GLP-1s. So just to give some context again about why and how important that was for the changes that we made. Then the only other thing to kind of highlight is that middle box in the top left, cost trend. So you can kind of see the trend from last year in the same time period, 13,068 per employee of cost, and we're trending at about 13,863. So it's about a 6 or 7% trend increase. And that's correlating to the plan increases that we are having in both October and for January of next year too. So just keep that in mind. The other thing, this is the January pool. Interestingly enough, I'll highlight that same cost trend box on the top left. So you can see the NDPHIT, or the round of the political subdivision group in January, is actually gone down significantly. And you remember one of the reasons why we've talked about in the last board meetings, some of those groups did make those plan changes that has made a huge impact in a positive way to the overall trust and significantly to the January pool. And then you can see what on the opposite side of that is the October pool, going from 10,315 to 12,589. So essentially, the political subdivisions are kind of subsidizing to some degree the adjustment that's being made there, but there is a bigger increase, if you remember, for October than January pool as well. And if you look at, going back just one other one, the top medical condition overall is in the bottom middle box. It's still cancer. That is our high cost claimant, #1, and musculoskeletal is right behind it. And we'll continue to bring forward those programs that we've discussed about how to manage cancer cases, and be a proactive cancer program, and also the musculoskeletal. We're going to share a little bit, into the next round of our population health team coming in future board meetings about essentially those 2 top categories. So anyway, just that's basically where we're operating in a snapshot. And the fourth area, so one of the big areas that we deal with all of our clients, is as well as kind of the growth in both technology, is the use of a tool that helps members and HR and communications, predominantly for these 3 areas. We call it engagement, advocacy, and navigation. So just because the phone is so popular, obviously, and everybody has apps on them, obviously, and the benefit world has really accelerated significantly in the last 3 to 5, I'd say the last 3 years, especially in trying to use those three areas: engagement, how do we engage employees? How do we create an advocacy that helps employees? And how do we navigate them to where they need for care when they need it? And not rely on HR for that constant source, or even to, having to figure out, how do I call someone? Can they just take my phone, click a tile and say, give me the answer? That's what everybody wants. They want it available quickly and they want it now. And that's the idea of this Strive technology. So our population health team, because of this information I'm showing you here, of the value of these type of apps and applications and resources, the engagement component, you reduce absenteeism, you increase the loyalty by employees, you increase productivity, and if you're a for-profit organization, you actually increase profitability. And there's a lot of data behind all this, but they've kind of analyzed it. This is actually a Gallup poll that they also feel about how employees are engaged. 41% reduction in quality defects, in other words, are the productive side of what they do every day more efficient and effective? And the answer is yes. Reduction in safety incidents, that's a big one. Reduction in turnover, because people will feel more satisfied because they can get the information they want more timely and more available. And then just the reduction in overall turnover, so the retention recruitment side of it. So technology in the right format and right structure can be very, very beneficial. So what our population health team did in conjunction with NDPHIT. So NDPHIT, for those who don't know, they're the kind of the back room to everything that NDPHIT does in supporting our BSwift platform. So they do they help with the premium collection for formulation in conjunction with what Brenda's team does. And then all the enrollment that members do and participate in is done on the BSwift platform. So they manage effectively the back room for both of those functions using the BSwift and as the platform. But then they also collaborate with our population health team, and they're always looking for ways, how do we bring these two things together? Population health wants to care about a person and provide resources, and NDPHIT is focused on what are the technology resources we can help in that fulfillment. So what is, why is this engagement? We already talked about some of those things. I won't belabor that point again. But really, again, what can you do to make it available, easy fingertips, and get access to the data? So this one here is Brown & Brown's. I showed this to Brenna. So if I want to know about my dental plan, my ID cards, or if I want to know about the wellness plan, I can click any one of those tiles and find out information. This is the first generation of an app in the benefit world, I call it, because it's good, it's accessible with good information, but it doesn't necessarily take me to those next levels of navigation and advocacy, which are kind of the next level of opportunity and use of an app. And that's what basically this Strive app does. So it's flexible for researching benefit programs. You can make it even specific to content that employer, so part of a trust. For those employers who may want to get more proactive at using this distribution app, they can do that. It provides robust employee communication tools, and it analyzes the data on the back about how many people are actually engaged in using different functions of this app. It does employee recognition and reward. So one of the things we're looking at, and we're not saying it's a solution right now, but it also can, if you have a reward system tied to your wellness program, it can create the incentive structure, manage it, and then each person can decide which program that you make available within there to qualify for or participate in. And then it's a true engagement platform. It's been studied by both of our tech team as well as population health team for over a year now, and they've kind of recommended that Strive app is probably the most forefront, simplified, cost-effective tools that's in the marketplace. And again, there's lots of functionality, and I won't go into all that detail of what it can do, but Here's what Dave basically presented. And the reason I'm bringing it up today is because we're vetting this and we're trying to get ahead of letting the board know that we're vetting this process and this app. And so we're not making a proposal to accept anything today, but we're giving you kind of a precursor of things that we're looking at. But as we've analyzed it, if this is something that is looked at and goes forward with, they've offered to do, to the trust, which this cost that we've highlighted here in the $255 per employee per month, that's about 30% less than what they offer. Brown & Brown offers 17,000 employees and all of our employer groups nationwide. So it's a pretty competitive pricing that they've offered the trust. Again, no decisions on it, but these are all the functionality that they would offer to us if we elected any of those options. And if something did materialize, they basically lay out a enrollment process or a time period to deploy it. Any questions on this as to, this again will probably go to this committee. You've got detail in the evaluation and the vetting. We'll do a lot of the front end kind of heavy lifting, and then we'll probably bring it to that committee. And then if it's an adequate or something I think that should be looked at or could be looked at, then the committee can decide whether you want to bring it to the board as a formal proposal and review and action. Any questions on it?
Yeah, Randy, this is Cole. So that fee that they're charging, is that for 1 year, 2 year, 3 year, or is it just an annual renewal?
All the terms, good question, Cole. We'd have to go back and look at their proposal. But I think it's a multi-year proposal. And the amount of the term period, that's the part I don't recall what it is, but that's something definitely we would look at.
So Randy, how long has this app been in existence? You had stated that
about
organizations
5 or
using
6
it.
years.
Okay.
Yeah, it's been around for a while. They've just continued to improve it and bring out additional capabilities of it and evolutions of it. We've also, and we're working with someone who works with other trusts that use it. So they've got experience actually in the trust environment as well. So because that was important to us as that's important as part of the vetting process. What's the functionality and the experience of trust members and the employees?
So really, in summary, what we're looking at is you're vetting this app. So there's a opportunity to consolidate all benefits that NDPHIT offers for employees who are in the plans to be able to have a one-stop shop, if you will, to be able to look at their benefits, their plans, where they're at with out-of-pocket, those kinds of things. Yes. I guess I'm not really sure what it all offers, but
yeah, it has the ability to connect, for enrollment. So if I want to do my enrollment through my app, you can do that. If you want to do if you want to find out information from a carrier, say it's Blue Cross, it connects you right into the portal where Blue Cross is. So literally it can take you from just information of content to a live environment, so if I want to look at the EAP program, same thing. I not just look at content, but I want to connect with someone who can help me at our E&I program. That's literally, that's why the engagement and navigation is. It's not just I want information, but I actually want to do something in a proactive way for me.
I have a question. This is Sonia. So will it kind of correlate with like BSwift, like the portal?
Yes.
Like their login credentials, and it'll just kind of communicate with the two pieces?
Yeah. So what they've offered basically is that's why BSwift, our EB Tech team with BSwift, as they're part of this proposal because they have a lot of employers nationwide on BSwift. And the Strive app is integrated into the bSwift application.
Okay, thank you.
But there's more to come, and there'll probably be, get a more, not just a vetting, but the committee, and then again, when it gets to the board, there'll probably be a more formal, kind of complete presentation, before it's again considered. And the last thing on here is just when we talked about standardization plans, minimum co-insurance, and employee and employer contributions. I think maybe, there's not really much more to report other than what we talked about in the last board meeting, but I think from a priority basis for this subcommittee, we'd want to get into a lot of details, and I'm sure you talked about it earlier, Brenda, but I think that would be just an important, priority that's looked at, because it's occurring in multiple parts of conversation. And this is important for many reasons. And one of the outcomes of not having the right structure in place is kind of what SEEK had to deal with this year. I'm gonna let Brenna and Angie kind of explain what occurred, and why it's so important that we have a really good structure for making just one thing to make a change, but we also have to have good solutions to help people. Yeah, I'll stop here.
So, I guess we have, Mike, you shared a little bit about how you've talked to your employees about changes you've had to make, and so, we wanted to share our story, which was not a pleasant one. Before Kyle left, he wanted to make some changes to the benefit plan to be good stewards of the trust. We had, I think it was a 12% 2 years ago, and this year it was going to be 13.8% at SEEK. So we had looked at two pretty high hikes in our premiums over the years, and we had a pretty low out of pocket and deductible that we'd had for as long as I've been here, forever, since we existed on our own. So we went through the process with John and Randy, and we changed just about all the things you could all at one time. We changed our out of pocket, we changed our deductible, and we changed our copay percentage to basically be the recommended standard. And our communication maybe perhaps wasn't the best, but we sent it out to the staff, the changes that we had decided, and we got a lot of uproar. We got a reply all email from one of our staff members that put everyone in a panic. I would recommend a lot of education before the announcement of any changes. Still today, a lot of people think their deductible is their out of pocket, and it's just, some people just don't pay attention until they see a big number, and then they're just think they have to pay that number. But the one thing that we did, we embedded our deductible in our out of pocket. We did not have an embedded one, and not sure if you guys know what that is, but with a family plan, if you're not embedded, you have to get to that number, 5,000, say it's 5,000 for your family deductible. On an embedded plan, one person can reach the individual deductible and they can stop paying. So if you have a family that just has one person with a medical need, they don't have to meet the family deductible, they can meet their embedded deductible, which is a great thing.
Yep.
For most people that might just have one high user. But in that, compliance said our individual deductible had to be $3,200 and ours was $2,500. And our benefit accumulators run 10/1 to 9/30. So anyone that had met their deductible of our previous $2,500 between October and January would now all of a sudden have to meet a $3,200. And then in January, start again with a new deductible of $3,200. So they were looking at $700 out of pocket for the people that used their insurance wisely and was gonna have everything done after they hit their deductible, mainly between October and January. So. I'm sorry, am I going too fast? So anybody, yeah, everybody get it, catch on. So people were looking out cash out of their pocket that they had not planned to do in this year. And they were pretty upset about that, and that was reasonable. We all thought that was a reasonable complaint and didn't want anybody to do that, so. After several weeks of many calls, and Angie thankfully did not quit on us. I was complaining to Randy about how anyone is gonna do this, any school that runs on an October benefit could never change their deductible. There, you know, how, we wouldn't put anybody through this. How are we gonna solve this problem? And he solved it in about 15 minutes. We put in something called a post-deductible HRA. So the cash that any of these people will have to pay to meet that new deductible will basically be paid by SEEK for those 2 months. And you can set it up, not all the cash, up to a certain dollar amount we offered to pay. So that was a pretty huge step for us to take kind of as the guinea pigs to anyone that wants to change their plan that has that benefit accumulator year of 10/1 to 9/31, which would be all the schools. Do you think?
Yeah, it's all the schools that would be in that situation. So to help everybody get the whole context, if you make any plan design change of any of the schools that are renew October 1st, that all gets impacted like they just experienced, which is October the 1st, all those changes. So that's why a lot of employers don't like to change the plan, because the calendar year deductible is corresponding to the calendar year and not the plan year. And so whereas the January pool is all January renewal to the calendar year of the deductible and the out-of-pocket max. So they can easily make a change, easier, I should say, without that impact of that 90 days. So there are some other kind of strategies of structure that we could adopt, but I won't go into them today because it's too complicated to explain for right now. But for the committee, we're certainly going to bring those ideas forward as to how to mitigate that, that potential exposure for the 90 days and make it easier for employers in our trust to make the transition.
And then throughout the rest of the year, we offer to pay 50% of the gap insurance. That's one of the offerings of NDPHIT too, and that helped quite a few people feel a little bit less worried about that higher out of pocket. So those were our changes. We definitely had a rough month of and John, who is now on the meeting, John Porter is our new executive director. Luckily he could say he did not make the decision, but he got to talk to the employees. It was very bonding experience for us and John, and in the beginning of his employment here. So
yeah,
John,
I got
anything else to add?
just a trial by fire on NDPHIT and changes like first 60 days trying to figure it out. Sorry I joined late. I had another commitment that I was on. I will say one of the things that Brenna mentioned, and this would be advice to all of you, once that kind of group email dropped, then as director, I jumped in right away and just tried to indicate to all of our staff that, insurance questions are really personalized individual questions and should be dealt with in an individual manner and not in a group sense, and directed them to start having conversations with Angie, Brenna, or myself on an individual basis as opposed to in a big group format, because it just that massive, that collective energy gets moving in the wrong direction and it just becomes so negative so fast. So when we were able to disperse it to a individual standpoint, we found out it was actually just a few staff that were going to be significantly impacted as we analyzed the numbers a little bit more. So then we really purposely targeted, not in a discriminatory manner. We looked at what was the necessary means that could be offered to everybody, but address the concerns of a few. And with like Randy said, with limited impact or risk for all of us. And I think we were able to develop both like the plans that Brenna indicated that alleviated the immediate kind of 90-day concern, October to January, but then also gave a bit of a parachute of comfort for the next upcoming year with that gap plan as well. And I think that those two things helped ease that pain where people could then process through. I actually got like a year, well, by the time we told them back in June or July, they had almost 18 months to begin to prepare financially for any change that might be forthcoming. The biggest concern is when you change that perceived out of pocket and increase that, it's not like that's the number that they look at. You know, immediately it's that's how much it's going to cost me. Well, no, it's insurance. That you still have insurance. That's what Brenda kept saying. You still have insurance. That doesn't mean that's what you're going to have to pay. So those are just a couple lessons learned from a rookie at this, I guess, to say. So I appreciate it, and again, apologize for being late.
Yeah, I think our plans are gonna be put in place long enough for people to understand that it's the worst case scenario is not affecting them. It could affect any of us, right? Any day, but I think to expect every year you're gonna have that worst case scenario of this out-of-pocket max. I think people will settle down into forgetting what their out-of-pocket max is again, because they didn't know until we told them it was changing, most of them. So, yeah. So that was our experience. We just wanted to make sure we shared with you how not to do it.
But I think you did bring up a good point, though. You know, for the political subs, this may not be as big of an issue because we do fall on a calendar year. But for those schools that are looking to make some changes that may benefit their premium allocation.
Oh, yes, and I forgot to mention the best part we went from 13.2 to a -2 in our premiums. So we're paying less in premiums next year than we did this year.
And I would add, like, if a school is targeting that plan or even considering a change, I would meet with Randy and talk about that HRA plan, that kind of 3-month thing. So if you're introducing that plan, you have that at the forefront to say, those of you who've met your deductible or probably will meet your deductible by October, we're going to invest in this additional plan that's going to help carry you through the end of the year. So no one will have to re-meet their deductible, then re-meet their deductible. Because that would have alleviated a lot if we had kind of headed that off before we initiated the change. So I think that was one of the bigger lessons learned. If we had known, I think we just kind of maybe overlooked or maybe took for granted, I'm not sure what the right word is, that deductible would reset in October. I don't think that was just common knowledge. I think everyone was functioning from a standpoint, well, change is going to go into effect July 1 or January 1, but in reality, it goes into effect October 1, including the deductible piece.
Well, thanks for your bravery in sharing that situation, because but I hate to say you learn from others' mistakes, but it's nice to hear some of the things that, you know, we all should be thinking about if we're looking at, particularly if the health committee brings forward recommendations like we discussed on standardization of plans and what that looks like. And I think transparency is such a critical part when you're making changes, because the two things I found out working in HR is you don't mess with people's pay and you don't mess with their benefits. And if you do, you got to make sure that there's a clear understanding of how that is affected. But appreciate you both, all three of you, and actually, John, welcome to the NDPHIT board and to the meeting as well. Okay, Randy, did you have any final comments regarding risk pool management? Okay, so Nora, we are up with a review of our financials.
Okay, I'm gonna make this slightly quick. As Keith mentioned about busy fall things, I have to leave in about 6 minutes for one of my kids. So if you do have questions, Brenna is also able to answer them. And I talked to her earlier about being prepared in case I do have to leave, but I'll try and go through this quickly and then maybe we'll all be done by 4:30. If you look at the balance sheet, as you can see, between operating cash, deposit cash, and CDs, we are now over 10 million in liquid assets within the fund. Having those premium pharmacy rebate receivables as well, we're at over 11.8 million in assets. Considering 10.2 of those are pretty much completely liquid, it's a really great place to be financially as far as cash flow, being able to meet any obligations, things of that nature. So those numbers do keep climbing. So those are always definitely nice to see. One of the things I will mention that Steve said about that, again, maybe in the new year after, the set of January renewals, when things slow for a little bit for Brenna, might be something to think about as far as investment policies, if we should go into more CDs or if it is time to consider other investment opportunities to try and maximize some returns on those cash balances rather than just having them sitting in some of the accounts they have made changes. We have it in First International where we get a sweep account, and it definitely helps with some of that income, as you see on the next page. But just something to start thinking about is trying to maximize some of those returns even more going forward now that we've kind of hit over that 10 million in cash and CDs type area. Liabilities are pretty consistent. The accounts payable is basically what we owe Blue Cross Blue Shield from the month before for the stuff that they've got outstanding. IBNR reserve, we usually only adjust that currently at the end of each year once the actuary comes in and says what the December one is. So that's why that stays the same. That went up to 3.5 for the end of 2023. So you can see our operating surplus is over 6.6 million. So not a bad place. It keeps creeping up. It's been good so far. Prior year, you can see was at 4.7, so almost 2 million increase in our membership equity at the end of August. Income statement. Again, I know it's a lot of information on a little page, but I just think it's nice to have some comparison. We have what August was this year, what August was last year, year-to-date total this year, and then year-to-date total prior, just so we can see where we are at compared to last year. August, not gonna lie, was probably our roughest month of 2024 as far as claims. That's in comprehensive, prescription, PPO, all of them. It was a rough month. You can see our loss ratio is 122% for the month of August. Sometimes that can come from different things. People were getting a lot of stuff done in the summer, wasn't being reported until August, or the claims weren't going through until August, things of that nature. So could be that's why, maybe it might be an anomaly. September might be back lower due to that, because through July, we had actually had a much better loss ratio through the year. But as you can see, we're still at only 94% year-to-date actual, having that rough month in August. And last year at the same time, we were at 97% loss ratio. And 3% is a big swing, so that's always good. You can see the increases. Premiums are up to 39.3 from 34 last year. Losses are up, but again, as far as percentage of premiums, we did kind of account for that. So it's not sitting in a bad spot. Our operating stays right at that 3% all the time. So year to date, we are at a net income of 1.7, and that is with a loss of almost 1.2 in August. So we were through July, we were up closer to that 3 million in income. August gave us a little bit of a hit, but still 1.7 for net earnings for the trust is a much better number than we've seen in a while. As you can see, last year at the same time was only 186,000 was the income. So definitely trending in the right direction. As far as membership equity and cash flow, we're sitting in really good spots financially. So the changes that have been made continue to do good things for the trust. So, but just through August, sitting in a good spot as far as that goes.
I found it interesting that not only with the claims costs from last year to this year, but also the prescription costs were up almost the same amount from that as well. So again, leads to your comment, Randy, about people probably filling their prescriptions early before these new benefits of Digby and those types of things coming in. It'll be interesting to see over the next quarter what this does to the financials moving forward. But I know you have to go, Nora. Thank you for the financial report. Does anybody have any questions in regards to the financials? Okay, thank you, Nora. Well, the last item on the agenda is our next board meeting, which, if my memory serves me right, is it December, Brenna? Is that right?
December 4th, I believe, on Zoom.
Yes, and it'll be a Zoom meeting as well. So anything else for the good of the order? Okay, well, thanks, everyone. Appreciate your time today, and have a great fall, and we'll see you all in December, if not sooner. Take care.
Thanks, Jenny.
Thanks.